Hello everyone, my name is Dr. Amod. I'm a pain specialist, and today we are going to talk about lumbar nerve root block or the transforaminal axis. And I've tried to make this presentation evidence-based, and I think there is something in it for everyone, whether you're a novice or an experienced person. And I hope you find it helpful. Okay, so the format of the presentation is going to be, we're going to talk about the anatomy and the basics in the beginning. Then we'll talk about the different approaches we use for performing this procedure along with the preparation we need to do. We'll talk about some steps and we'll look at some contrast patterns when we're performing this procedure. And in the end, I'll give you some references and some key points to remember. So before we start, I think it's important to differentiate between radiculopathy and radicular pain. Radicular pain is just a pain which is going in a radicular fashion. In contrast, radiculopathy is supported by sensory and or motor signs which become important. Now, let's start with some basics. The first thing is the lumbar nerve root is named according to the upper segment under which the nerve runs. So let's take an example of L4-5 level. So the nerve root running below the L4 pedicle and coming out is the exiting L4 nerve root. So it's named based on the upper segment. Now there are two nerve roots. One is the exiting nerve and the other one is a traversing nerve. When I show you the next slide, I think this will become clearer. And this has got practical importance. Why do I say that? Because you might want to change the level of your injection based on which nerve root is involved. So let's take an example. So let's say this is L vertebra and this is L5 vertebra. And this is where the L4-5 disc is located. Now, what I have marked with the cartoon over here is the exiting L4 nerve root. Why L4? Because it's coming below the L4 pedicle. So that's the upper vertebra. So it's the L4 nerve root. And now what I've marked with the cartoon is the traversing nerve root. So this nerve root, which is traversing the L4-5 disc, is actually coming out from the L5 level. So it becomes the exiting nerve root at the L5 level, whereas it is the traversing nerve root at the L4-5 level. Now, why do we need to understand this difference? Now, let's say there is a disc at the L4-5 level and there is a disc bulge in the posterolateral quadrant. Now, the nerve root which will get involved is the traversing L5 nerve root as it travels like this and comes out below the L5 pedicle. So if you are doing an injection at the L4-5 level, you might not get the outcome because the actual problem is traversing nerve root being impinged by the L4-5 disc. And hence, if you need to do a nerve root block, it has to be at a lower level, which is the L5-S1 level. So let's move on. Now, before I move on further, I think there are some things which you need to understand and know about. So there is a separate video on my YouTube channel about how to optimize your C-arm imaging and what are the things you need to know about your C-arm. I think it's an important thing if you're trying to get the best images and the best outcomes. Similarly, there's another video on contrast agents, which ones to use, which ones not to use, how are they different, also on my YouTube channel, and I encourage you to see that because that'll help you get a comprehensive insight and knowledge into what we are doing. Now, before I move any further, another video which I will produce will be on the X-rays of the lumbar spine, as in how to interpret, how to look at things. So that's something you should watch out in the future, and that's why I've labeled this slide as number 1, because that's one video which I'm going to make in the future. So if you're interested in learning more about what we are seeing on the lumbar X-ray images for doing these interventional procedures, I suggest you do stay in touch and subscribe or keep a lookout for my future videos. So now if you look at this X-ray image, there are a lot of structures in this image. Some of them are anterior, which means more towards the tummy, and some of them are posterior, which means more towards the back. So in this next image, I have highlighted the anterior structures. These include the vertebral bodies and the pedicles. And overlapping these structures are the posterior structures. I have highlighted them in the second image. And these include the superior articular facet, the transverse process, the inferior articular facet, the lamina, the spinous processes. So all these anterior structures are being overlapped by the posterior ones. And you need to be able to differentiate them so that you can guide your needle in the right place. So just to show you a few images before we start. So this is a lateral image of the lumbar spine. You can see the sacrum at this level. You can see the L5 vertebra. And you can see the contrast spreading along the anterior epidural space. So let's look at another image. So this one is showing you the posterior epidural space. You can contrast it with the other image, which is on the right hand side. And now let me show you another image where you can see contrast in the posterior and the anterior epidural space. So these are basic things which are very important for one to know, and I will be covering them in more detail in the lecture which we make on the X-ray imaging of the lumbar spine. So another important part, we have to know about the vascular supply of the spinal cord. And why is that important? Because anteriorly, there is only one artery, and posteriorly you've got the two spinal arteries. And the anterior thoracolumbar spinal cord is heavily dependent on this anterior spinal artery. This anterior spinal artery gets contributions from a number of radiculomedullary arteries, and one of them is quite big and very critical, and it's called the artery of Adamkiewicz. If you injure this artery, the consequences can be disastrous in some cases, like you could call the paraplegia. So hence, we need to know about the vascular supply when we are doing these procedures. Now, this big artery which reinforces the anterior spinal artery is generally on the left-hand side. Approximately, say, 69 to 85% will have it on the left-hand side, whereas 15 to 31% would have it on the right-hand side. It can be located at variable levels, and different studies have found they're located at different levels. Some studies would say they're between T11 and L2, or these are the two common levels, and the range can be as high as T8, and they can go as low as L3, but I've even come across studies which say even L5 or S1. So it can be quite variable in its position, but it is more common in the left. And we need to know about this artery because when you're doing this procedure, we want to stay away from this one. So the radiculomedullary arteries, they are present at each vertebral foraminal level. In the thoracic spine, they arise from the intercostal arteries, and in the lumbar spine, they arise from the lumbar arteries. Now, these arteries would travel through the foramen, where this is where we are targeting the injection, and they have relatively fixed course, although the artery of Adamkiewicz or the big artery can be at a different place, but the course remains generally fixed with little variability. And if you are targeting the superior anterior portion of the foramen or the mid portion of the foramen, then you need to be extra careful. Later on, when we go on further, you will realize that the safe triangle we talk about is in this area. So actually, how safe is the safe triangle is another question which arises. The first thing or the basic we need to know is we need to look at the foraminal anatomy. So this is an anatomical model which is not as accurate as in normal life. When I say that, I would expect this nerve root to be a little bit higher up, just below the pedicle, but I think this is just a model. But the whole purpose of looking at this model is to look at this foramen and know about its anatomy. So if you look at anteriorly, you've got the vertebral bodies and you've got the disc in the inferior part. If you look at the posterior part, you've got this lamina and you've got the superior articular processes. And also posteriorly, you've got the ligamentum flavum, which bridges this area. Now, if you look at the superior and the inferior border, there is the pedicle above and the pedicle below. In this foramen lies the nerve roots, the blood vessels, fat, and veins. Moving on. Now, if you want to do a nerve root block, why do you first want to do a nerve root block? There are certain advantages of the nerve root block. Number one, you can be very specific in terms of what you're targeting and where you are. Number two, you put the drug you're planning to inject as close to the site of actual pathology in the anterior part of the epidural space, and that gives you better results. So hence we prefer the nerve root blocks. The commonly talked about approaches are the sub-pedicular approach, which means going below the pedicle, the supra-neural approach, which means going above the nerve, the retroneural approach, which means going behind, and the infra-neural approach, which means going below the nerve. Now, all these approaches have their own advantages and disadvantages, and many of them have got other names as well. But this is the terminology used most often, and especially by the Spine Intervention Society. And so I would stick to this terminology. So this needle which I've traced is sub-pedicular, which means the needle is going below the pedicle. And if you notice, it is ending just at the posterior border of the vertebral body. So it's going quite deep. Now, contrast this to the other approach, which is the supra-neural approach. Again, the supra-neural approach is also going below the pedicle, but if you notice, the end point is in the posterior part of the foramen, not going as far as the vertebral bodies. So the depth of the needle is different between the two approaches. Now, if we talk about the retroneural approach, you're putting the needle just behind the nerve. And then if you talk about the infraneural approach, the needle is going below the nerve. And if you notice, it's in line with the disc. We'll talk about each of these approaches in the subsequent section. So let's move on. So when you're doing a nerve root block, regardless of whatever approach you're using, you start with identifying the correct level, and you can count the vertebra, and you can look at the MRI which was done before to make sure there is no sacralization or lumbarization. Then you can do the squaring of the target vertebra. It is important to square that vertebra where you're going to do the procedure. Once you've done that, you go oblique towards the same side as the procedure is being done. And once you can see the Scotty dog appearance and you know your landmarks, you can put the needle. Once you've got the needle in the correct position in the oblique view, you switch over to the lateral views to make sure the depth of the needle is okay. Once you're happy with the positioning of the needle, you put it in contrast, you check again in the AP and the lateral views to make sure the contrast is spreading where you want it to spread. And then this is followed up by the injection of the intended mixture. You save the images, and once the procedure is completed, the patient is shifted out of the procedure room and the monitoring is done. And when he's ready for discharge, you give the instructions for discharge. So this is the sequence of what you want to do when you're doing a nerve root block. Now let's look at each of the approaches we talked about previously. So we are starting with the sub-pedicular approach, which is the needle going below the pedicle and as far as the posterior border of the vertebral body. You start by squaring off the inferior end plate of the indented vertebral level of the upper vertebra. So let's say I want to do an injection at the 3-4 level, which are these two vertebrae. I would square off this end plate, which is sometimes when you square off a vertebra, you will square off all the end plates. But sometimes you have to choose between which end plates you square. And if that's the situation, you want to square off the inferior end plate of the upper vertebra. So for this level, it is this end plate we are talking about. Now, once you've squared off the vertebra and you know which level you're working at, you will go oblique till you see the Scotty dog. And then in the AP view, your target level would be at 6 o'clock position, which is just below the chin of the dog or just below the pedicle in the middle. Now, if you had to choose, then you're better off going a little more lateral than going medial, because if you're too medial, you can enter the dural sleeve or the dura, which you don't want. We've already talked about the safe triangle concept, and there are blood vessels in there. We'll talk about this where this is located in the subsequent slides. Now, once you've achieved the right needle trajectory in the ipsilateral oblique view, which is the oblique of the C-arm towards you, to gauge the right depth, you go onto the lateral view and then you adjust the depth of the needle. Sometimes you don't even need to go oblique, especially in young patients when there are no osteophytes, the bony landmarks are very good and clear. You can go in the straight AP view, provided no landmarks are in your view. When I say landmarks, I mean the transverse process, I mean the lamina. And if you go straight in, often you can just get in where you want to. And the aim is not to be too medial. So just to show you a practical demonstration, so I'm counting levels over here. I can see the last rib over here. So that's T12, this is L1, this is L2, where my needle is, if you notice. Then I move on to the next, keeping the needle where it was on L2, I can count the subsequent levels. So this next one is L3, and then I can move the C further down to count the subsequent levels. So once you've counted your levels and squared the end plates, look at this vertebra. When by squaring of the end plates, I mean there's only one line at the end plate. Can you see that? Look at this vertebra. There are two lines I can see. So this one, this end plate is not squared. This end plate is not squared, whereas this end plate is squared and this end plate is also squared. So once you've got your end plate squared, you change to the oblique view, which means your C-arm goes towards the side of the injection tilted. I'll show you the images in the subsequent slides. And what you get is this Scotty dog appearance. Now, if you're struggling to see the Scotty dog, this is how it looks like. And let me make it clearer for you in this subsequent image. I've marked it. Can you see the Scotty dog now? This is the ear of the dog, this is the face of the dog, this is the chin, and this is where the needle is for the sub-pedicular or the supra-neural approach. This is the front paw, this is the back paw, and this is the body. So each of these parts of the dog correspond to different things, and I label them for you. So the ear is the superior articular process. This part protruding in the front is the transverse process. This is the pedicle. The neck is the pars interarticularis. The front paw is the inferior articular process, and this part is the lamina. So they're all labeled, and if you compare this image with this one, you can easily make out what I'm talking about. Okay. Let's move on. So this is a patient who's lying. We're going to do a nerve root block. So we've got the C-arm positioned at the right level. So for the lower levels, I'm going to do a caudate tilt, which is in the direction of this arrow. So we're trying to square this vertebra. Look what happens to the images. It's not squared. I can still see two lines over here. I can see two lines over here. I can see two lines over here. And I can see two lines over here. If you know what I mean by the two lines, that's the end plates. This is the two lines. Look at these two. Now I'm going to do more caudate tilt and look what happens into these end plates. Can you see now they've merged into almost one? So at this position, I'm looking through the L5S1 disc and I've squared my end plates. There's only one line visible over here. There is one line over here. Whereas over here, I can see two lines. The end plates are visible separately. And same goes for this level. The end plates are visible separately. So if I'm doing an L5S1 nerve root block, I have squared the inferior end plate of the upper vertebra, which happens to be L5. Now I'm going to go oblique. So by oblique, I mean if I'm doing an injection on this side, which is the left side of the patient, the C-arm goes this side. If I'm doing an injection on the right side of the patient, the C-arm goes towards me. And that's the ipsilateral or same-sided oblique. So this is how we have gone oblique towards this side. And now you can see the dog, the face coming up, the superior articular process coming up, the front paw coming up. So that's the Scotty dog appearance we were talking about before. So let's move on and actually do the injection. I'll give you some examples. So in this injection, I'm targeting the right side, which is this side, the L4 and 5 level. Now in this image, you can see this is the L4 vertebra. I have squared the inferior end plate. However, the superior end plate can be viewed separately. There are two lines over here. I have squared the upper end plate of L5, but the inferior end plate, two lines are visible separately. So we have got squaring of the vertebra. We have got the Scotty dog appearance, with this being the chin. My needle's right below the chin at 6 o'clock position. This, I'm just directing my needle. It's going a little outward, so I'm going to redirect it. Now it's almost like a tiny dot, which means I'm in the gun barrel view. What I mean by gun barrel view is I'm in the same plane, in the same line as the X-ray beam is going, so the needle looks like a dot. So now I am happy with my needle position. It's gone deep enough. So I switch over to the lateral view, and you can see in the lateral view, this is L5 vertebra, this is L4 vertebra. My needle's in the posterior superior part of the foramen. So this is a supra-neural approach. Often when you enter the foramen, you'll get a giveaway, and that will tell you you've entered the foramen. Now you give the contrast and you can see the contrast spreading up over here. I'm happy with the contrast position in this lateral view. So I'm going to switch over to the AP view, and this is a straight AP view with a craniocaudate tilt to square the vertebra. And I can see the contrast flowing inwards and slightly downwards as well along the traversing nerve root. That's self nerve root block on the right hand side. Now let's do the next level, right? L5S1 nerve root block. So this is the pedicle. We can see this is my needle, and if you notice, the end plates are squared. So that's my first needle insertion, and I've redirected my needle to make sure I'm going in line with the X-ray beams. That's why it's looking like a tiny dot now. I've readjusted my needle as I want it to be. Now I think I'm happy with the depth of my needle, so I'm going to switch over to the lateral view, and you can see the needle's coming at the L5S1 level, and it's going in the posterior superior part. So it's a supra-neural approach. However, if I was to push the needle till here, it will become a sub-pedicular approach. Now you can see the contrast spreading, which has just come up over here. I'm happy with the contrast spread, so I'm going to go to the AP view. Again, I can now see the contrast spreading and going along the nerve root sleeve. And if I give a tiny bit more contrast, I can see even a better view. So that's the L5S1 nerve root block. Now, let's move on and talk about the safe triangle and the Kambin's triangle. This, along with the vascular supply of the spinal cord, is another thing I'll make a separate presentation on, because this is an important topic. And you might see a video coming up on this in the near future. So the safe triangle is seen in the lateral image. It is this part. This is now totally not a lateral image, but an oblique image. So if this is the pedicle and then this is the vertebral body and the nerve roots coming out like this, it's this area where we do the sub-pedicular and the supra-neural approach. Now, we've talked that there are blood vessels in this area, so we have to be really careful about it. In this safe triangle, the hypotenuse is formed by the exiting nerve root, the superior part by the inferior border of the pedicle, and this is the lateral part. Now, contrast this to the Kambin's triangle, which is below the nerve root, And this is something which comes into play when we are doing endoscopic surgeries or when we are doing the infra-neural approach. Some authors believe that this is a safer approach to use. And this is like a three-dimensional structure. On the medial side, you've got the traversing nerve root and the dural sac. On the lateral side, you've got the exiting nerve root. The lower boundary is formed by the upper end of the lower vertebral body. And the posterior part, because it's a three-dimensional structure, is the superior articular process and the vertebral body. So that's the Kambin's triangle. This is where it is situated in the same diagram. And the reason we talk about it is because some authors believe that this is a safer approach to use. Moving forwards, let's look at the supraneural approach. So the supraneural approach can also be considered as a sub-pedicular approach where you pulled the needle back from here to the posterior superior part of the foramen. Or it can also be considered a retroneural approach where you move the needle above the nerve. So you're not going till the spine, the floor of the spine, and there are some separate arteries over there which you can avoid by using this approach. Whatever approach you're using, it's always good to do a real-time imaging when you're putting in the contrast. So let's see the retroneural approach. This is a better image which I'm using in this display. With the nerve is shown where it should be in the upper part of the foramen. And when I do a retroneural approach, I'm just behind the nerve. So if you were to mark the boundaries of where the end point of your needle should be, you can draw a line separating the posterior 1/3 with the middle third of the foramen in this direction. And you can draw another line separating the upper 1/3 from the lower 2/3 of the foramen, where the point they intersect is where your end point should be. Or you can just hit the lamina and just advance a few more millimeters. But you have to be careful because if you hit the nerve, obviously you will get the radicular symptoms, and sometimes that leads to increased pain, and you don't want to intentionally do that if you can avoid it. The infraneural approach is where the nerve is below the nerve. And what you do in this approach is you put the needle just next to the lateral border of the superior articular process. So actually your needle is going straight for the disc. So you have to be very careful. If there are any bulges in this area, you need to look at that before on your eye. Also, you need to go lateral more often and check that you're not kind of going intradiscal. That becomes very important. But yes, it does have its own advantages. By advantages, I mean that sometimes you get the exiting and the traversing nerve root in the same injection, especially the L5-S1 level where you've got the traversing S1 being impinged. This could be quite a useful one. So you go in the lateral views halfway till the foramen, and you have to be careful not to inject into the disc. So this is another image showing the infraneural injection. As you can see, the needle is going straight for the disc. So you need to go into the lateral to make sure you're not too deep. So let's look on the X-ray images. Where do you place the needles when you're doing these injections? So the needle at 6 o'clock position is for the supraneural and the sub-pedicular approach. And as you know, the depth is the thing which is different. If we talk about the retroneural approach, the needle would be a slightly lower down. And if we talk about the infraneural approach, this is the superior articular process. This is the lateral border. It's just on the side of that in the lower half of the equator. And this is the infraneural approach. So let's look at some normal contrast flow patterns. Okay. So this is again a sub-pedicular approach. You can see the Scotty dog. You can see the superior articular process of the S1 and the needle's right in the middle. The depth is adequate for the supraneural approach. I've given the contrast, it's flowing there. I can see that. And in the AP view, I can see the contrast spreading like this, and there is some contrast over here as well. And if I put some more contrast, you can see it clearly. Now this is a little challenging one because you can see Bertolotti syndrome where the sacral area is fusing with the transverse process. So your landmarks would be a little tricky and different. This is another example where we're doing an L5-S1 nerve root block in someone who's had spinal surgery before, and you can see the contrast spreading very nicely. This is the kind of pattern you want. This is another one where you see it spreading nicely. This is in the mid region of the foramen, the needle contrast spread. And then if you see it in the AP view, you see it spreading very nicely. And if I was to take the mid-pedicular line, my needle is quite medial to that. Now, this is a challenging one where we're trying to do an injection at the level where previously surgery has been done. So sometimes when there's metal work, your landmarks are obscured and you can see the contrast spreading inwards, and in the lateral view, the contrast spreading over here. These are all my images. I've collected them over the years. Again, a difficult case where we've got the needle ending in the supraneural in the in the posterior superior part of the foramen, the contrast spreading over there, and you can see it spreading nicely along the nerve root. Again, a difficult one where the contrast spreading nicely, same patient, different level. Okay, so when you're putting contrast, it's good to have an extension tubing because that enables you to do a live screening. Otherwise, your hand would be in the picture. So the extension tubing should be primed with the contrast, and also while connecting and disconnecting the fringes, the chances of any needle movement are reduced with the extension tubing. So the extension tubing gives you obvious advantages. Live screening helps you pick up which helps to pick up the inadvertent contrast flow patterns sooner. Now, the bevel of the needle when you're manipulating the needle should be in the direction where you want the correction to be done. And when you're putting the contrast, you want to use very small volume because if you put too much of contrast, the further landmarks might be obscured. Now, I've kept these images because the contrast is flowing outwards, it's not going inwards. So this means the needle needs to be repositioned. Same in this image, most of the contrast is flowing outwards, it's not going inwards. With a little bit of repositioning, now you can see the contrast has started to flow inwards. Sometimes those finer positions with the depth and the medial make all the difference. Now, so this is the kind of extension tubing you want. This is an example of the contrast you use. If you have access to digital subtraction imaging, then that's really useful because it can sometimes help you pick up the finer intravascular contrast spreads. If you have put in a lot of contrast, then the choices are give it some time and put some saline in that area if you want to, or sometimes you have to come back at a later date. Whenever you're doing the nerve root blocks, please do save images so that you can document the final position of the needle and the extent of the contrast spread, and that's visible for anyone to review later on if required. Now, the S1 foraminal block or nerve root block is a separate ball game, which I want to cover in a separate video, but I've got some good images to show you how that's done, and you can see the contrast spread along the S1 nerve root in both these images. We'll talk about that in a separate video. Now, you've understood the technique. Let's look at some evident contrast patterns which you should be able to recognize. So when you're taking the image to look at the contrast, you should have more of proximal segments visible because any flow from the arteries is going to be carried in that direction, and you should be able to scrutinize the cephalate spread and pick it up. Some people think that CT guidance is very safe and it removes this risk of giving an intravascular injection. In fact, that's not true. The CT guidance limits the amount of contrast spread we can visualize because the scanning takes time and the contrast might have gotten washed away. However, it does or it can help us to position the needle more finely. So you should do what is routine for you and what you are more happy with. So let's look at this. This is the pre-contrast image. Now I've given the contrast. And can you see the spread over here? If you weren't looking with a fine eye, you might not have seen. There is something which has come up over here as well, which wasn't there in the image before. So that's how minute it can be, and that's how closely you have to look at the images. Let me show you the same patient in the lateral. So this is the same patient, the block being done in the same level. And can you see this contrast coming up? You might not be looking at it or expecting it to come over there. And unless you're looking closely, you would miss it. So this is the normal image after the contrast has been washed off. And if you're not taking images immediately, you might miss the contrast intravascular flow. Let's look at another contrast flow pattern. So the needle's in the middle of the foramen, and this is the level of surgery, and this is the disc. And look at what happens when I give a little bit of contrast. I can see it spreading here, but can you see it spreading elsewhere? If not, look closely. I'll give some more. Can you see anything different now? Still not able to see it? Let me show it again. Some more contrast. Did you see what's happening over here? So although my needle is away from the disc, but there is intradiscal spread. And why does that happen when I'm so far away from the disc? This is the intradiscal spread. And that happens because there is a disc bulge, a significant one, which is extending in different directions. And hence, I might be away, but I still might catch the disc. And that's something always to keep an eye out for. So this image I've just kept because sometimes you need to save an image before you give contrast. This is also an interlaminar epidural, but this can be really confusing. What am I seeing over here? This is actually calcified aorta. And sometimes when you're given the contrast, you might imagine this to be as contrast spread. So you are better off saving the images I've just tilted, I've changed the oblique, and you can see how the shadow of the aorta has shifted from one side to another. So don't mistake this for the contrast. I think contraindications are obvious ones. I'm not gonna dwell over it, but I've just included this slide for the sake of completeness. This is a good article to read. It says that transforaminal nerve root blocks can be considered for subacute radicular pain, and I think it covers the topic quite nicely, so it's a good one to read, although it's more than a decade old. I think it came out in 2010, if I'm right. Yes. This is a good document again to read. It's produced by the Faculty of Pain Medicine, Royal College, and tells you about what are the standards when you're doing epidurals or nerve root blocks. Firstly, it says that it's included in the guidance or the pathways for care of these patients. Secondly, it says you have to take informed consent. And when you're taking informed consent, even if the chance of the adverse outcome is very little, but it's a serious adverse outcome like paralysis or nerve injury, it's a good practice to inform the patient about that. Also important is talking about the outcome of not taking any action so that the patient can understand full comprehensive picture and take an informed decision. It also talks about telling patients that the steroids are being used in an off-label manner. They've been used for years and years and years, but this is off-label indication for the use of steroids in this group. If we talk about the procedure, they say you should have the appropriate environment, not only for infection control, but even for the kind of assistance you have, the imaging you have, the resuscitation and the post-procedure. Standards of care should be met. Fasting, it's as per the local guidelines and what you prefer. The checklist has to be there. You have to have a trained assistant, and the assistant should be at least trained in intermediate life support. It's a good practice to put the cannula. You should store your images so that they're available for review. Take aseptic precautions, use the contrast license for this indication, and then the records have to be complete. And this is the list which they give for you to document, and I think we can all judge for ourselves how many of these things we document or where the scope of improvement is. Now, post-procedure, the patient should be seen by a team member, check for any numbness or weakness or any urinary issues like retention or headache, any limb weakness or sensory loss which is significant or headache may require overnight admission, and if there has been a dural puncture, it may need prolonged admission. You should give patient advice on what are the symptoms they should be seeking urgent medical or emergency care for. You should have tie-ups of facilities for an MRI or a neurosurgical or spinal surgical opinion. And at discharge, the patient should have a telephone number to contact, and follow-up arrangements should be in place and clearly communicated to the patient. Now, that's all I need to talk about the presentation on nerve root blocks. However, I think it's important to talk about that there have been some who have come to significant harm in form of paraplegia, and I think it's called as a black swan event. It's something which you don't expect to happen, but it has major consequences, and it happens most often due to embolization or damage to the big anterior artery, which we talked about. What can you do to prevent it? Review the MRI scans, have DSA, digital subtraction imaging. If you have access to that, use that. Avoid particulate steroids, because some of these studies quote that there has been no paraplegia documented with dexamethasone or non-particulate steroids, and it makes me wonder, is it the particulate nature, or are there other mechanisms such as spasm or damage to the artery which are also playing a role? You should use live fluoroscopy, tension tubing, blunt and short beveled needles. With regards to what is the best approach, there are authors with different beliefs. Some believe Kambin's is safer. This publication, which I've quoted over here from 2017, talks about 18 cases of paralysis, and some of them had injections under CT guidance, and even some as low as L5-S1 or S1 level. So the artery can be really variable. But what they also found was the needle was positioned in the superior portion of the foramen in 77% of the cases, and less commonly in the mid zones. Is that attributed to because we do more of supra-neural and sub-pedicular approaches? Is that the reason why we found more of these, or is the vascular supply being more prominent in the upper part? The reason behind this is something which we all need to dwell and think about. And also they said the anterior placement of the needle was more commonly associated with this complication. So if you're using a sub-pedicular approach or a supra-neural approach, this might help you to decide which one you feel is better. And when the authors had published this in 2017, they made a note that no cases of paralysis had been documented in their knowledge with non-particulate steroids. So I think that's it. I hope you found it useful. And if you did find it useful, please do keep in touch, subscribe to our YouTube channel, write in comments, because whatever you write in there does encourage us to produce more for you. You can see this takes a lot of effort, and that encouragement is required for us to deliver. So thank you.